Expiratory flow limitation is a component of normal breathing. When anybody makes a forced expiratory movement, it is limited because flow limitation occurs. However, we now understand that when expiratory flow limitation occurs with the patient breathing quietly, that this is an important component of a disease like chronic obstructive pulmonary disease, and it predicts a different natural history and has significant implications for the patient. Expiratory flow limitation occurs differently according to how you're seated or whether you're lying down. If you're lying down, then you are more likely to get tidal expiratory flow limitation than is the case if you're sitting up. So if you want to know whether somebody has flow limitation, you should really test in both positions, and particularly if you want to know whether you're going to use treatment that works with the patient supine, you definitely have to test that way. There are a number of ways of evaluating expiratory flow limitation in COPD patients. You can do it in a laboratory where the patient swallows an esophageal balloon and has the volume of air breathing out recorded, but that's very complicated and involves a lot of data processing. You can make laboratory measurements of the maximum flow volume loop and position the tidal breathing loop within it. That's relatively inaccurate and is certainly affected by the previous breathing history of the patient. By far the most accurate way is to measure the change in reactance within an individual breath, and that can be done measuring with a technique called forced oscillation. And that's the technique which is now becoming more popular and more widely used to identify the presence of expiratory flow limitation in COPD patients. The major advantages of using the forced oscillation technique, and particularly detecting the change within breath of reactance, sometimes called in the trade delta XRS, is that it is non-invasive, unlike, say, swallowing an esophageal balloon, and it is more accurate than other methods. For instance, a commonly used approach has been to measure a forced expiratory flow volume loop, and then to position the tidal flow volume loop within that bigger flow volume envelope. That is relatively inaccurate, whereas the forced oscillation technique is independent of the volume history and is extremely accurate in defining the presence of flow limitation on an individual breath and also for an individual patient. When a patient has expiratory flow limitation under resting conditions, it's highly likely that they'll be unable to expire completely down to the true relaxation volume of the respiratory system. That means that they develop dynamic hyperinflation. Effectively, they are running at a higher lung volume than is comfortable for them. If you can detect and identify EFL, then you can have a good idea that the resting lung volume is elevated. Raised lung volumes are associated with more breathlessness, more limitation of exercise capacity, and if you treat that problem, the patient's condition improves. So it's really relevant to identify whether expiratory flow limitation is present and whether end expiratory lung volume is increased. The major problems in treating EFL in the ambulatory COPD patient are twofold. One, I'm sorry to say, is lack of awareness amongst the physicians who are managing these patients. A lot of our data about the importance of tidal EFL as a new clinical sign in managing COPD is pretty recent, and so that information needs to be disseminated. But the other big limiting factor is the availability of simple, accurate, and relatively affordable ways of detecting this. Fortunately, there are developments on the horizon that are going to make a big difference to this, and that will allow the much better screening in hospital and crucially at home of the presence of flow limitation in our COPD patients.